Welcome to the Health Leader Forge. My name is Mark Bonica. I'm a professor at the University of New Hampshire in the Department of Health Management and Policy. And ordinarily, I'd be introducing myself as the podcast host for today, but I'm trying something new. I've invited one of the students here at the University of New Hampshire to join me as a guest host. So I'd like to introduce today Samir Panesar. Hi, Samir. Welcome.
Hi. Thanks for having me.
So you want to tell us a little bit about yourself?
Sure. Yeah. So I'm a senior here at the University of New Hampshire, and I'm a political science major, but I also have an interest in healthcare in a broader sense. So that's a little bit about me.
Great. Who did you invite to be on the podcast this time?
Well, for this time, we spoke with Dr. Skip Homicz, Families First Health and Support Center in Portsmouth, New Hampshire. He's the dental director there.
And why did you reach out to Dr. Homicz?
Well, Dr. Homicz is somebody who in the state of New Hampshire has had a really interesting career. For most of his career, he was in private practice in a small town in New Hampshire, but then later had a second professional life in terms of starting the dental component of the federally qualified health center in Portsmouth, and is somebody that's really interested in a career in dental medicine, but also more broadly in delivery and payment reform within the world of healthcare. He was somebody who I wanted to hear from in terms of his unique career in the world of healthcare.
And you have an interest in dentistry as well.
I do, yeah. So I'm hoping to pursue a career within dental medicine, but one that, maybe strays off the track a little bit of most practicing dentists.
Okay. Strays how?
Strays in terms of trying to tackle some of the broader challenges and opportunities that I see within both oral healthcare delivery and more broadly within healthcare delivery.
And what did you learn from the interview with Dr. Homicz that you didn't know about him before?
Well, something that I knew about him before, but I think was enhanced throughout the interview was really how humble of a guy he is. One of the things that really kind of stood out to me was when he was talking about the homeless component and providing dental care to the homeless population in New Hampshire. He said that he was probably the person that got the most out of it in terms of how it made him feel to be able to provide services to people who normally don't receive such a type of service. So I thought that really spoke to the kind of person that he is and the kind of things that he values. So that was probably one of the takeaways about him. The other thing that I really took away was how much opportunity there is in terms of making things happen that aren't necessarily fairly standard. The way that he got involved with Families First was by a recommendation and just to serve as kind of an advisor on how to develop the dental component. And obviously his career ended up blooming into being much more than just an advisor. So that really got me excited about, having a career that, I'm not entirely sure what it's going to encompass, but I'm sure that there are plenty of opportunities out there like that. And it just takes being a little, looking for certain opportunities and getting out there and talking to folks.
Awesome. You did a great job on the interview, so I'm really excited to share this as a first student-led interview. Hopefully we're going to do a bunch more like this. So thanks again for doing that. And here is Samir Panesar interviewing Dr. Skip Homicz.
Welcome to the Forge, Dr. Homicz. So you went to Cornell University in New York. How did you decide to go to Cornell, and what did you study?
Well, I guess it starts early, even in growing up in, kind of the middle school setting, the high school setting. My sciences were pretty strong. I had a great relationship with a primary care doc, family doctor at the time, and back in those days, they were making house calls and all that type of thing. I remember him helping me through some science projects. So it started there. I had summer jobs. I worked in a hospital in as an X-ray technician. I actually, was an autopsy assistant at one point. So I became oriented in that with the strength in sciences. And really wanting to sort of develop into a desire to be in the medical world. So then why Cornell? Coming out of Western Mass, small high school, I played football. So that was a factor, and I was recruited to a bunch of different schools, and there was a challenge in Cornell that didn't exist in some of the other locations. In fact, one of the coaches said, you ought to come here because I'm not so sure you can do it at Cornell. So let's go. So I ended up at Cornell University.
Excellent. What did you end up majoring in?
Cornell at the time had a strong, a strong requirement in languages in their bachelor's. I was in the School of Arts and Sciences in the bachelor's program, and it almost killed me. Although I was good in sciences, language was not my bag. But I started looking at zoology. I ended up with biological sciences, which offered me a broad range throughout that major and the minor. And it also got all the requirements in for medical dental school.
So after college, you enrolled at Columbia University College of Dental Medicine, where you earned your doctorate of dental surgery. How did you decide to go into dentistry, and why did you pick Columbia?
So actually, kind of stepped back. While I was in high school, I played American Legion baseball, and I had taken batting practice. And after batting practice, I was walking out behind the infield, just kind of just to field some balls, and not looking, I got hit in the head with a line drive, and I woke up at Wesson Memorial Hospital in Springfield, Mass. And attending to me on that Saturday afternoon was a neurosurgeon. And we got talking over the couple days that I was there, and he said, what do you want to do? I said, well, I want to be a doctor. He said, he said, look at me. This is Saturday afternoon in the middle of the summer. It's a beautiful day. I'm here. You want to be a dentist. You're still part of the medical world, and you're dealing with basically healthy people in the big picture, and you're not going to find yourself in the hospital on Saturday afternoons. So, that might be the introduction to it. I got close to some dentists going through time, and so I applied to both medical and dental schools. And just when push came to shove, just decided to go to the dental piece. Why Columbia, though? That's a significant piece, because Columbia's first 2 years is with the medical students. It's in the medical school. It's Columbia Presbyterian Hospital in New York. So Columbia was in New York. I really wanted to get to a major metropolitan area. I wanted to be at a major medical center, and Columbia offered me those. Also, at the time, it was one of the smaller classes. We started with 42 students in my class. And I thought that was potentially a big benefit too.
After dental school, you were in the U.S. Navy Dental Corps for 2 years at the Portsmouth Naval Shipyard. What drew you to the Navy?
Well, so now we're going to go back and we're going to age me, which is where I belong. We're now talking the late 60s, and for as history goes, that was Vietnam era. And so we were all concerned with our military obligations. My dad was a veteran of the South Pacific, so we had that background there, and a desire and a need to serve. Going into dental school, had offensive time, and we were all going one way or the other. So Dad was Navy. To tell you the truth, if I could avoid the jungles of Vietnam, that was a good deal. While I could still serve, that was a good deal. Also, coming out of dental school, residencies and internships weren't as big a deal at that point. So the Navy was going to offer me the opportunity to grow and practice for a few years, however that number of years that might be. So at that time, it was 4 years of I went into dental school in the reserves. So that was 4 years of reserves and 2 years of active duty, and that's how it came down.
What was the work like, and what responsibilities did it entail?
Yeah, I think I hit a somewhat of a unique situation. I came right to Portsmouth, New Hampshire. Here, the shipyard, which at the time was Portsmouth was a full-blown military city. Pease was a 10,000 people hospital. The Navy situation had the shipyard, the prison, and a hospital. But the dental clinic was 3 junior officers, senior four-striper captain, and we had our own lab. We had an oral surgeon available at the hospital. It was a wonderful learning experience, one I couldn't have hoped to be any better. So I was basically allowed, within the parameters of both the military and this clinic, to do what I wanted to do. We had a sick call, so we dealt with emergencies, and then we treat and planned our own cases and provided the services, and we could pretty much. I came out of Columbia with a lot of clinical surgical experience, and I felt ready to go in those areas. And I was really, we were allowed to run with it from the practice standpoint. So we were monitored, however, but we weren't on any treadmill or anything. I didn't find myself on amalgam lines, which would be routine stuff day after day. There was a lot of variety. It was a very, very valuable experience.
So being a clinician, such as a dentist, is an important part of an individual's identity. When did you know you would really internalize that part of your identity? So in other words, when did you really feel like you were a dentist?
Well, that's an interesting question, but you spend 4 years of undergraduate, 4 years of dental school, and dental school is tough, you get beaten up. So you kind of come through it, you pass, you have to take these boards, these clinical boards, these national boards, and you come through it, And so it didn't take me long to be glad to be called doctor. So I'm going to say they gave me that diploma, and, I reported for duty as a dentist.
So after the Navy, you went into private practice in Antrim, New Hampshire. How did you decide to go into private practice, and why did you choose Antrim?
I think my thing was, I was always looking at private practice. Also, at the time, the public health sector in dental pretty much wasn't there. But again, if you want, we can reflect back to probably your first question, how'd you get to where you were? I remember working in one of my first college summers. I worked in a quarry, a redstone quarry, and that was before the big days of OSHA. So you'd be in these hot summers, down in these holes, working jackhammers, and then the coffee truck would come at about 10 o'clock. So I decided at that time that I wanted to be the guy who dictated when the coffee truck came. And that, it makes for a little humor, but there's really truth in it. So my answer to your question is I kind of wanted to be my own boss. And that was, I knew at that time that I could do that in a private practice. Why Antrim? When we were in Portsmouth, we were looking for quality of life, and this is something dentistry allows you to do. I mean, you can pick where you want to go. You can still do. You could then, you can now. Portsmouth was a very military town, a lot of crime. We had one child at the time. My wife was expecting number 2, and the schools were on double sessions. So we had decided at the time that Portsmouth wasn't really where we wanted to be. So we just started west. We did know we liked New Hampshire a lot. So we wanted to stay in New Hampshire, so we went west and started looking at areas. The Monadnock region was, nice small town, a little bit kind of some sophistication. And then we looked at the best place. It was really the hospital people were semi-recruiting, saying, this is a good place to be. We need some dentists. And where do you put the practice? I talked to dentists at the time, and there was a lot more of that going on at that time too. Kind of consulting or chatting, and a lot of openness. This is what is. This is what could be. And so a couple of physicians had space in the small town of Antrim, which was just north of Peterborough. And let's set it up. Let's do. So I rented space there and equipped it, and let's go.
Were you in solo practice, or did you have a partner?
Yeah, no, I opened the door. First hired, a receptionist to answer the phone before I left the military. I made a few trips over there to see some emergencies while I was still in the military. And then grew from there. So I needed somebody right away. You had to write some pretty big checks. By today's standard, they were small. But still, you had to equip, at least 2 treatment rooms. You had to have all the X-ray equipment. You had the furniture in the reception room. You need the business stuff in the business office. You had to hire a second person as a dental assistant. Certainly, it was all four-handed dentistry, and even to this day, if my assistant doesn't show up for work, I don't work. So we needed 2 people, and I opened the door and waited for people to call.
What were some of the similarities and differences in Antrim as compared to your position in the Navy?
Yeah, huge differences, and I think there's a parallel between the Navy. Navy is a public health part of the public health system, and so there are parameters around what you're going to do and how you're going to do it, and the standard of care is the same. Scope of practice might be different. You might in the Navy be told, well, you're not going to do these. Somebody else is going to do the root canals, or somebody else is going to do the extractions. I didn't run into much of that. But indeed, going into private practice, you control all the variables. You decide where you're going to be. You're going to decide how you're going to do it, whether you're going to be in a solo practice or a group practice, and you're going to decide what procedures you're going to be performing. And of course, you've got to be able to back that up with the education and the standard of care and all. But a lot of flexibility, a lot of ownership. You're the boss, and the Navy, you don't have that level of freedom.
So you were in private practice for 32 years in Antrim. What made you decide to stay in private practice there?
Private practice was really rewarding. Private practice was everything that I hoped it would be. It really allowed me to develop my managerial skills, really develop my professional skills, my communication skills, and entrepreneurial skills within that professional level. It allowed me to interface, as did the Navy, as does the public sector, with people. So why did I stay? So I got into it and enjoyed the growth in all those areas. You stay with it though because of the people. And if you ask any dentist who gets out in retirement and you ask them what they miss, they don't miss fillings or extractions or root canals. They miss the people. And the relationships that you develop and that grow over those number of years are just absolutely invaluable. And so that's why I'd say it was no problem staying with it.
While you were in practice in Antrim, you became the Monadnock Component Trustee to the New Hampshire Dental Society for 4 years. How did you decide to get involved in the New Hampshire Dental Society?
Well, to be sure, I don't care what profession or business, we have responsibilities to that. In the professions, we have a responsibility to the profession, and to elevate the profession and the standards of the profession and the practice of the profession. And in dentistry, it's the American Dental Association, basically. And the American Dental Association is tripartite. There are 3 levels of it. There's the national level, the American Dental Association. There's the state level, which is the New Hampshire Dental Society. And then there's the component level. So in New Hampshire, I'm going to say there's 9 components spread across the state. So the Monadnock region was that component that I was exposed to, and I just felt as though I had a responsibility to be part of that organization.
What did that position entail? What were your responsibilities?
Well, the responsibilities were, to some degree minimal. I mean, we met probably at the most once a month, maybe every 6 weeks, and at that level, there's a lot of collegiality. Dentistry can be insular, and in fact, I was in Antrim, New Hampshire, small town at that point, all by myself. If I don't get out there, I don't get feedback, and you can get very stale. You can get very set in your ways. You can think you know it all. So those opportunities to be part of that Monadnock component, and then take, there's the collegiality piece, there's the education piece. What's going on in Keene? What's going on in that whole area? That was my responsibility to take that back to the state, to the New Hampshire Dental Society, to the board there, because that, as that component representative, I sat on the board. So, and then it worked the other way also. You take what's going on at the state and the responsibilities there, the educational pieces, the opportunities, you take that from the state level back to the Monadnock region in that component. So that was pretty much the extent of those responsibilities.
So in 2003, you became the dental director at the Families First Community Health and Support Center in Portsmouth, New Hampshire, a position that you still hold to this day. Tell us a bit about Families First. For those of our listeners who are unfamiliar with what federally qualified health centers are, could you expand on what they do and what role they play in our healthcare system?
Okay, bring me back to that question. But if it's okay with you, I'd like to tell you how I got there, how it happened, because a lot of my life and experience is putting one foot in front of the other, and to some degree, that's how this happened. I was winding down my practice. My practice built in Antrim, and to the extent of we ended up with 3 dentists and a whole bunch of hygienists and probably a staff of 13, 15 people. So it was a really great operation, but I was winding out of it. And as the last kid was out of the house, my wife said to me, we're living in Peterborough, my wife says to me, I want to go where there are people. So we had been back and forth to the seacoast and up in Maine and all that. So I said, you know what? There's no really reason not to. My partner, with whom I had a wonderful experience, a wonderful transition, and indeed I would recommend today that people, get into associateships and have others close to them. But he was in place, and there was no reason we couldn't come out. We couldn't. So we moved over to the seacoast. At the same time, I'm going through the chairs of the Dental Society, and other things happened too relative to oral health care, nationally. But as we moved over here, I had some time on my hand, and at that time, Families First, the federally qualified health center, was looking at putting in a dental center. So we tied in. They contacted me. I contacted them. Whatever it happened, they asked me if I'd stay close and do some consulting relative to the implementation of that dental center within the federally qualified health center. So that's how I got involved at the beginning. Well, what's a federally qualified health center? It's a primary care setting which is community-based and patient-driven. The board of a federally qualified health center has to be 51% patients. It provides, all built around primary care. Here at Families First, we've got primary care, we've got prenatal, dental, behavioral health, homeless outreach, different addiction treatment programs. We have family and parenting classes support. And for the population that comes in, we have case management and care coordination. And a federally qualified health center is basically designed and located where access is an issue. So we exist to provide access to services for people who have problems in that area of accessing healthcare. So the beauty of the federally qualified health center, and the reason I've stayed involved to the point I am, is the model. So we're dealing with people who have access to care. Our patient population, 2/3 of them are below the federal poverty level. Now that's about $20,000, area of $20,000 a year for a family of 3. Another 25% are between that $20,000 and 100% of poverty level and 200% of poverty level. So for those populations, for everybody under 100% of the poverty level, the dental is provided at a nominal fee. Between 100% and 200%, it's a sliding fee scale. So you can imagine with a population, a demographic like that, these folks don't just have a toothache. These folks come in with a myriad of chronic disease exposures, depression, diabetes, hypertension, smokers. We don't see a lot of smoke. I don't interface with a lot of smoke. I do a lot of smokers, here. A lot of drug issues, a lot of polypharmacy, people exposed to a lot of different things. So this is a magnificent model to be able to deal with all those pieces under one roof, regardless of the ability to pay. So I hope, in a nutshell, that's a picture of what a Fed. Now, the saying around federally qualified health centers is, if you've seen one federally qualified health center, you've seen one. They're all a little different. They can be in locations in cities and dense populations where certain populations don't have access. They can be in very rural areas where there are no providers. They can be in areas where specific populations aren't addressed. In our case here, we started, the health center was really started as a health center. It started earlier as a prenatal center, but about 1997. And soon after that got its FQHC designation. They got it because of the homeless outreach program. And so you go around Portsmouth, New Hampshire, and you say, "Excuse me, a homeless population problem?" And I'll say, "Yep." So we're able, under this one roof, regardless of the ability to pay, to address this multitude of issues and provide this level of support and integration.
Could you talk a little bit about comparing the difference between your private practice in Antrim and being here at the FQHC?
When I came to Portsmouth, and they wanted to put a dental center in, I really didn't have a good focus on what the difference was, or for that matter, what I was getting into. I definitely came out of private practice for 30 plus years. That's where my experience was. So, in private practice, you pretty much decide, you decide what you're going to do, how you're going to do it, and the patient pretty much decides what services you teach them. You give them their options, and they make the choices. And when you come into Families First, you see a very, very different population. But in this sector, we're dealing with fixed resources, with fixed assets. We only, let's say we only have so many resources to go around a certain population. So the choices are narrower. The scope of practice is narrower. We're going to do fewer root canals and more extractions. We're going to do fewer fixed prostheses, and that's, we're going to do fewer implants and more removable prostheses. So the patients, the facility has more input into the services that'll be provided and the patient probably they have the same choices actually, but in reality they're more limited because of financial choices. So there's a big difference there. The other huge difference in private practice, we saw basically healthy people. It was and remember, I'm in Etherington, New Hampshire. I'm in a very rural New Hampshire area. I'm not in Bedford or some other place that you might think that you might think Portsmouth, very affluent. But I thought I was seeing it all there. But these folks did not come. If they came in with those chronic diseases that I talked about before, they were being managed. They were being treated. So my job was much easier. I did the dental work. I did the dentistry. I didn't have to deal with the medical complications. I come here to Families First and say, "Wow, we're going to take your blood pressure. Ooh, before I touch you, you're going to go see primary care. We'll take the diabetic, the same thing." So the focus here, we necessarily need a focus on the whole body here, on the whole person. And it's, like I said before, it's a wonderful model for that because of the population we see. But it's a night and day. I didn't understand what was out there when I was in private practice. I loved it. I think the services provided were tremendously valuable. I think they were tremendously appreciated. But I didn't understand the population that was outside of that was not accessing my private practice. So there's really a very significant difference between the two practices.
You said earlier that if you've seen one FQHC, you've seen one FQHC. Is it standard to have a dental practice in a federally qualified health center, or is that something that makes Families First unique?
It is no longer unique. It was unique when we initiated this. I'm going to say we were one of the earlier ones. I think there's 10 or 11 FQHCs in New Hampshire right now, and I think the numbers are about the same. There's about 75% nationally of dental services are provided at 75% of the FQHCs. And there's about, I'm going to say 1,350, 1,400 federally qualified health centers across the country. So that's the frequency of dental services in these centers is increasing, and the reason it's increasing, and the reason it was even established, it was the same reason they did it right here. When the hospitals in all areas have to do needs assessments, and what kept coming up in these needs assessments, in either number 2 or 3, was oral health. So we've kind of backed into this as you're providing, and it's not just here, but it's everywhere. People walking in with dental problems, you can't be healthy without a healthy mouth, or with active dental disease. You're gonna have that contributing to coronary artery disease. You're gonna have it contributing to diabetes. You're gonna have it contributing to preterm births. So that's the reason for the expansion of oral health, and it's been heavily supported by the government.
Let's talk a little bit about your position here at Families First. What is your role as the dental director? What are your responsibilities?
Well, remember that I'm a volunteer here in this, which is unique unto itself. And I have grown here with it. I was here day one. I came in here, and basically they looked to me to set this place up. And I set it up just like my private practice. Well, I had a learning curve. And so that learning curve applied to both the practice of dentistry and in the growth through the leadership piece. But to some degree, I always think, what are the responsibilities of the dental director? And you think of them as administrative. One responsibility, of course, is the clinical piece, because in almost anywhere there's a dental director, they're also one of the primary dentists. So there's the dental treatment piece. And then the next thing you think about is the administrative piece. And that's being part of the chain of command, that's policy, that's monitoring different matrices. But I think that one of the biggest responsibilities of a dental director is team building. In effective dental care delivery, oral health care delivery, effective and efficient, teamwork is absolutely critical. So I would say the primary responsibility of a dental director is to develop that team, and then to look at how you can effectively and efficiently manage that team and provide services. Along those lines, we're looking at policy development. implementation. It's very similar to any operation where you take the needs of the operation of the agency, apply those to the dental center. You take the needs of the dental center and kind of titrate those against the needs of the agency and the patients.
How many people are employed in the dental practice here?
That's good. We have a real. It's actually similar to my Navy experience, because it's a small operation, and because it's a small operation, boy, we can turn things around here. We can implement program. We can implement changes. We can put a policy in place, see how it works, reevaluate it, and change it very, very quickly. So the specific answer to your question is we have probably 1.3 full-time dentists. We have our dentist is never without 2 assistants at all times. We have 2 hygienists that rotate through. That's here in the fixed center. As I said, we have a homeless outreach program too. So we're in Exeter with a van and partnering with St. Vincent de Paul over there with a dentist and a hygienist once a week. We're up in Rochester with a van there with a dentist and an assistant, once a week. We're at Crossroads with a dentist, assistant, and a hygienist. Crossroads is the homeless shelter here in Portsmouth. So we're down there, and since our fixed structure is so close there, we bring the clients, our patients, back up here for that. So we do it. We also deal with. And we're blessed to have a significant volunteer dental corps of probably about 4 dentists who help us with most of that outreach and with filling in behind our 1.3 paid dentists here when they want to go on vacation, when they go on attending courses, when they're out of here. We've got a fixed facility here that's nothing but overhead and not fulfilling its role of providing access. So these volunteers fill in around those times that the full-time dentist is out.
How many patients are served here annually in the dental center?
The dental center sees about 2,000 patients. The agency itself sees a population of about 6,000 over all its programs. Like I say, it's a fair number of dental patients for a practice this size, but it does allow us a lot of flexibility in how we do and what we do.
What are the unique challenges of serving the Families First population versus your experience in private practice? In other words, what kinds of dental procedures are done? What are the differences in patient need?
That's a very good question. And so what you're really addressing is a scope of service. So let me start with standard of care. Our standard of care has got to be exemplary. It's got to be as good. It's got to be as good as it can. These services can be gotten anywhere. It's as good as my private practice was. So what we do, the quality of it, has got to be as good as it can be. Now that said, we provide a broad spectrum of dental services. In fact, we provide any service that you can get in a private dental offices. We stress prevention. We provide thorough diagnosis and treatment planning. We provide emergency care, and we do a lot of those pieces. We provide comprehensive restorative care, and that's all about fillings. We're charged by the government and by Medicaid to eliminate, to do the services of examination, treatment planning, but also to eliminate dental disease. So we will address the active disease of dental caries and periodontal disease. So past that, Now we're looking at restorative, at rehabilitative care, where teeth are lost, where people are having trouble, functioning. They might have trouble getting a job because they're missing a front tooth. So we're talking, that's rehabilitative type of stuff. And that's where we're going to start to differ from the private sector to some degree, because we're seeing a different population. We're seeing that population that's almost all of it is below. We see maybe 15% private insurance here. The rest of it is about 60% of it is between Medicare and Medicaid, and there's no dental benefit in Medicare. It's very limited, reimbursement for services under Medicaid, except for children. So the choices are the same. We can provide, say, a fixed bridge or an implant, but the expense level is at usual and customary, as opposed to our sliding fee scale. We at our levels of compensation, nominal fee for 2/3 of the population, we wouldn't be here if we were providing implants for those nominal fees, and that goes to the core difference, between the two practices. By the same token, with that limited scope, we still fill the need. We can put teeth in that smile with something removable that looks great. The patient that comes in and has a toothache, in my private world, they might go to the wall to save that tooth. In this patient's world, they've got up, the kids are screaming, the car didn't start. The solution to that patient's problem is taken care of by getting that tooth out. So it's a little different world in that respect. So the specific answer to your question is the scope of services is narrower here, although anything is available.
You've alluded to this a little bit, but could you talk a little bit about the revenue and billing at Families First as opposed to being in private practice?
Families First, and pretty much any place, I think, in the public sector, is a lot easier for the dentist. We're charged primarily with patient care. The rest of the operation here is charged with the administrative piece. So my job, Dr. Fitzsimon's job, is to clinically manage that patient and provide them with the options. Those options then go with the patient to the treatment coordinator, and that's where the financial arrangements are made. Dentistry, and all the financial arrangements are made, and all the appointments are made. We actually have some of the same issues as far as compared with the private sector. We need people to show up. Well, generally in the public health sector, we have a much higher no-show broken appointment rate. In some of the clinics that I've seen, that can run as high as 25-30%. That means 1 out of 4 people don't show up. That's disaster. Now we've got this whole system, this building, we've got these assistants, we've got all this fancy equipment sitting here and doing nothing. Not only that, the people who need it aren't getting in. So we have to be able to manage that in some way and prevent that. The other thing that we haven't touched on that I'd like to mention is the cost of dental care. When facilities and agencies look at putting dental centers into their operations, they think of it, okay, we'll put a dermatology clinic in, we'll put an allergy clinic in, and they find out very quickly that it's a different animal. And many of them, in the earlier going, when these were initially being put in, a lot of them folded. We had Exeter. We had a clinic here in Exeter, fold. They just, by their standards, by their parameters, they just couldn't do it financially. Dentistry is very expensive service to provide. Everything's expensive around it. The personnel, it's not only the diagnostic piece of primary care, it's the treatment piece of the surgical operation. It's the people that are needed. It's It's all the HIPAA and the OSHA. And so it's very, very difficult to balance that bottom line and to do it it's difficult enough. And this is why dentistry is expensive in the private sector itself. It isn't, it isn't all going home. It's a very expensive service to provide. And even here, we need to be providing these services at these reduced fees. We need to be more efficient, more effective with our time. We need those financial arrangements to be made and kept. We need people to show up for their appointments. But we do have the benefit here of the rest of the infrastructure of this clinic. So we'll send somebody out here, and we have dedicated people for dental, but there are areas, some of our appointment people are confirming appointments, are doing it for medical too. So we use some of the resources. All our insurance goes out by some of the same people who deal with the medical piece. So there's real value in the infrastructure here that the practicing dentist really doesn't have to deal with.
Why do people choose to get their dental care from Families First and not from a private practice?
Yeah, that's another good question. We exist to serve populations that have trouble accessing care, but all are welcome. And in reality, I would love to see more people who can pay for their services or have more private insurance. It would help us a lot with our bottom line. Why do people come? It's that sliding fee scale is a huge benefit. We slide down, our nominal fee here is $35. So somebody comes in for an exam and x-rays, that's $35. Well, if they're below the federal poverty level, and somewhere in between. So the quick answer to your question is, finances have a lot to do with it. That said, again, we provide all these integrated services, integration, under one roof and regardless of the ability to pay. That's why they're coming here. Could others come here and receive the same scope of services? Absolutely. The same standard of care? Absolutely. I encourage them to.
In 2009, you expanded your role here by becoming involved with the dental care to the homeless component of Families First. Could you talk a little bit about that? What did that role entail?
Well, so I came out of private practice, Antrim, New Hampshire, and I thought I knew it all. So I came in here and I learned I didn't know it all, and then we started the homeless piece. And again, the reason we started the homeless piece, the homeless piece was in place. That's why we originally had our FQHC designation. However, as these nurse practitioners and physicians and primary care folks went out into the field and saw these homeless people, they came back pretty quickly. And once we had this dental place, and then they said, Dr. Homicz, these folks need dental as much as they need anything else, and we can't deal with some of the primary care issues until we get these dental, infections and pain and suffering and all this under control. So therefore we put the dental piece or the oral health piece into the homeless outreach. So my personal experience with that has been absolutely enlightening. I never used to ask the next question. I get the information that I need and run with it. So, for instance, boy, you got a lot of. When did you see a dentist last? Well, I saw him when I was incarcerated. I would usually let it go at that and track the clinical piece. I ask the next question now, and it will be, why were you incarcerated? And this may seem like an invasion of privacy, but it's very interesting that these folks, to a person, are glad to talk about where they've been. And where they've been is so enlightening that this population is out there. I didn't have a clue what was going on while I was in. I had no idea. I had heard about homeless, but I didn't really know what it meant. I knew people slept in their cars, but I never saw the cars. I have some great patients, some patients that are bright, appreciate our services, and they live in a tent in the woods through the whole year. So enlightening in a humanistic way for me. And then these folks are so appreciative of the minimal services that we provide them. If you can take care of my toothache, I'm a happy camper. The other services that we provide are cleanings, because some of these folks come in and a lot of oral health issues are kind of genetically determined, and it's all a resistance to disease. Well, some of these folks are very resistant, but so we see a lot of them come in and say, "Can I get my teeth cleaned?" And you make people really happy with that. And you know what? Making people really happy is really rewarding. And so for my piece in this whole thing, to think that, I've had the opportunity at a second professional life. Boy, I tell you, there's nobody around here more thankful than I am to have been exposed to this homeless piece, to this population that accesses the services at this agency.
Let's transition just a little bit. You've also been involved in the New Hampshire Dental Society, serving as a chairperson and its president from 2004 to 2005. Could you tell us a little bit about the organization? What does the New Hampshire Dental Society do?
Well, so the organized dentistry is basically built around the American Dental Association, a tripartite organization. The ADA in Chicago, nationally, 70% of the dentists in the country, the state level, Hampshire, maybe 80% of the dentists, plus a couple hundred hygienists, a lot of dental providers, and then the component level. So the New Hampshire Dental Society, the American Dental Association, are the go-to people in knowledge of oral health. They provide information, education, and support. So the New Hampshire Dental Society does that same thing on a state level. We provide support for the profession, to elevate the profession, to be able to address the oral health needs of the people of New Hampshire, citizens of New Hampshire, and to make available to them the best oral health care available. So it's support for the profession, it's education, it's advocacy. It's advocacy for the dentist, for the profession. We do a lot of legislative work from the standpoint of either supporting or initiating or coming out against. It's very interesting. If you haven't had the experience in New Hampshire, and probably anywhere, citizens want it their way. They want this or they want that, and they'll go to their legislature, and the legislator wants to support them. The legislature really doesn't know much about many of the things that they have to deal with. I found this when as I was going through the chairs, and indeed had to go in and testify, fairly frequently on oral health issues, and I found doing that was also enlightening, because these legislators, we're not necessarily always on the same page, but there is a level of ignorance. They can't know everything, and needless to say, most of them know very little about oral health care delivery. So we're in there, quite a bit on it from an educational standpoint, and dealing with the issues that the dentists have to deal with in both the private and public sector.
What is your involvement with the New Hampshire Dental Society consisted of? What were your responsibilities as a chairperson and as the president?
The chair is just trying to get things done, and we have 9 components. So getting the components around one table, hearing what's going on, developing policies and positions. as big as anything, when I came through the chairs of the New Hampshire Dental Society, access to oral health care just hit the fan. In 2000, the Surgeon General wrote a report on the state of oral health, and he called it an epidemic. And he identified the disparities across different populations. This brought in the government and foundations. And again, just as I didn't see it when I was in Antrim, the profession in the big picture hadn't seen it either. So as I came through the chairs, my goal, my primary interest was to bring that knowledge of that need to the profession in New Hampshire, and to bring that private sector. We've got oral health needs as a population. Federally qualified health centers, the clinics, they're not going to get it all done. The private sector has to be involved in the solution of these issues. So, my job, my focus at that, as I came through the chairs, was bringing the public sector into an awareness and a participation in the needs of the public sector.
What do most people misunderstand about the field of dentistry? You're at a dinner party and you meet someone and tell them that you're a dentist. What are they most likely assuming that is wrong? What have you most often had to explain to people about what dentistry really is or really like?
Well, at the dinner party, I'm going the other way. I'm going to avoid that discussion. As I'm talking to someone interested maybe in coming into the profession, I mean, what are the stereotypes? Expense, pain. Well, I'm gonna go very quickly to the fact that we control pain. Pain is very. People talk about we'll talk about root canals and how this went bad and that went bad. And I mean that's the medical world we live in. We practice, and some do. For the most part, dental healthcare delivery is very effective. It can be expensive. It can be expensive for the most part. In two areas. One is where people opt for certain aesthetics. Expensive to deliver, expensive to be provided. They can be expensive when there's neglect, and you have to play catch up. So there's really no dodging those two bullets. When I'm dealing, if I'm at that dinner party, I'm there's some angst involved there. But when I'm dealing with someone who looks as though they want to go into the dental profession, I'm going to talk about, or even that, even let's go back to that patient and say, who does that. Most patients love their dentist, so they may raise this or this issue or that issue, but you're going to talk to the highest percentage of people who say they have a great relationship with their dentist. And so, I'd push that piece.
Let's transition our talk a little bit to talk about leadership, especially in your current role at Families First. What is your leadership philosophy?
My leadership philosophy is simple, and it's one that I employed in my family as my wife and I raise children, and it's basically modeling. Do the right thing. In dentistry, as I said, I try to build teams. As far as leadership is concerned, in building that team, the participants, the assistants, they need to buy in. So they're going to buy in if they believe in me, if they believe in the mission of the operation, the agency, the clinic, and they're going to buy in if they feel they're making a significant contribution. So that's got to be built on time. Dental healthcare delivery is hard. I mean, it's physically tough. So we've got to work hard at it. From a leadership standpoint, they've got to see that. Once they see that, it's very unusual that we don't get people working really hard behind us. Also, there's from the standpoint of, really, I'm a wet finger dentist, and what is always, a couple of things have worked is when if I see results that I like in my staff, I'm going to praise that. I do the same thing with my kids. Results that I want to see or activity that I want to see repeated, I praise it all the time. I do that. I do that here. The other piece is with my dentists or others. It's a see one, do one, teach one. So here, let's look and see how this is done. I'm going to demonstrate this one to you, and I'll do that with the assistance group too. This is how I would do it. Let's see you do it, and now take it off and teach it to somebody else. So in the big picture, I'm about the modeling piece, the trust, building the trust piece, and going from there.
What are the characteristics and behaviors of a good leader, and how do you aspire to those yourself?
I think this comes back to the previous discussion here too. I think you gotta lead by example, and it's really easy to go to the technical stuff. As a good leader, do you dot your I's, and cross your T's, and you got to do all that stuff. But a good leader builds trust. A good leader builds relationships. Dentistry is no different than anything else. It's a people business. It's a relationship business. That's the good news. Can it be mechanical? Can it be all about fillings and root canals and crowns? Absolutely, and those play a part. But the satisfaction, the reward, the effectiveness, I feel strongly, is in relationship building and trust.
What do you look for when hiring and evaluating leaders?
One of the first things I look for someone who listens. I look for someone who I believe can, when I get a chance to look at them, are they buying into the mission? I need you to be part of the mission. And your behavior is going to tell me that. Are you listening to me? You don't have to take everything I say, or I don't necessarily take everything you're going to say. But I'm going to learn who you are. You're going to learn who I am, and we'll take what we want and leave the rest. The other thing I really like to see is someone who looks for responsibility and executes it.
Could you give us an example of a difficult leadership lesson that you had to learn the hard way?
The hardest thing I have ever had, and I still have to do less of it here, but is terminating someone. And in Antrim, I had a staff member who had been with me for some time, and for various reasons, I had to terminate her. So I called her in. You hire at the beginning of the day, fire at the end of the day. So I got her in at 5 o'clock, and I said, look, I really appreciate you've been with me. We've had a great relationship, and I talked to her forever, and I said, that's it. She showed up for work the next day. So I wasn't very effective in my firing. She didn't hear me. So I learned a lot from that. And so, but that is the hardest thing to reject people to me. I mean, you put you can change people, but not much. And you learn that over time too. You learn to make some quick, some pretty quick judgments and evaluations. Try not to judge people, but you can certainly evaluate them. And when you see things that really aren't going right, and so the difficult pieces are all in staff management. You can't have one person out of sync, or they can poison the whole system. So controlling staff is the biggest challenge. And again, probably my biggest failure was that staff member that showed up for work the next day after being fired.
Let's talk a little bit about mentorship. Did you have a mentor or mentors early in your career? How did that person help you if you did? Was it a formal or an informal relationship?
Wow. Wow. I use the word mentor, and I think, geez, did I meet this person a bunch of times? Did they walk me through this? Did they help me with that? I didn't have a lot of that. I had a father, though, who set standards, big time. See, we can talk about leadership, we can talk about oral health care delivery, we can talk about FQHCs. There's morals and virtues. And you can't get by those, and so it starts there. For me, it started with my family. I had a couple, and as I came through time and even through my adult life, I had a couple parish priests who have been tremendously valuable to me, tremendously helpful. Coming through school at Cornell, I had an assistant dean who took some interest. I struggled through my first year and a half at Cornell University. I really struggled. He was there for me. I got to, in my interviewing process and everything at Columbia, I ran into another, dean there who was, who was able to talk to and get through that, so I can identify those people through time. So as far as mentoring, as you get into the profession, again, dentistry can tend to be insular, and it's dangerous. So you've got to get outside of the operatory, outside of the treatment room, outside of the clinic, and that's why continuing education for dentists is and oral health care providers is critical. That's where that's why the Dental Society, the collegiality piece. It isn't just about, hey, let's have a meal together and a drink, let's solve, that happened or this happened. So, that's a level of mentorship. That's a level of peer review. So, the continuation, even when I was in the Navy was great on continuing education. I remember going to Walter Reed and hearing a colonel, and the colonel's name was Bashkar. And I listened to that man and said, wow, this is great. I went back and heard him every time I could possibly hear him, and I did the same thing when I could when I could identify with somebody. And we did a lot of. You spent a lot of time on developing communication skills and staff development and how you do that. That all came through continuing education, and so each one of these people, as I grabbed down, they were really a mentor, huh? They weren't necessarily someone I met for a cup of coffee or a cocktail or something like that, but they were out there for me. So the exposure to outside influence, beginning at my family and my faith, and coming right through to my wife, was tremendous. Dentistry takes a ton of time. It's changing to some degree now, but boy, I didn't get home until 7 o'clock at night. Well, there was never an issue there, and there was tremendous support, and that's got to be there. That's a level of mentoring. That's a level of listening. So it all happens there. It doesn't just happen at that professional level.
Do you mentor other leaders now? And if so, what do you get out of being a mentor?
It keeps me young. My son's a dentist, and he started. He's up in Cape Elizabeth in Biddeford, Maine, and this mentoring thing goes both ways. And so, I never knew how much I knew until my son came out, and indeed not just him, but when I started to see these younger dentists come through here, my expectations were unrealistic, and I didn't understand that. I didn't understand how much I knew. And I'm nothing special, I just, like I said, I'm a wet-fingered dentist. I put one foot in front of the other. But over 30 years, you learn a lot, especially if you're out there. And so, we got a lot to share. So, yeah, I try to keep it in a very informal way. I hate to, you don't like to come down from the top. I like to come in from a level, from a level playing field, peer to peer with other dentists, suggest things, throw things out. Another one of my, throw the mud and see what sticks. And I do that with my son. I do that with our dentists, the dentists that have come through here. They have the rewarding piece to see them develop
and they develop fast, and they're smart. And like I say, it's a two-way street right now. I get, do I have some things some information and knowledge to share? Sure. But boy, they bring a lot to the table too. And so the reward again, we come back to relationships. That's where this is a big picture. This is a cold, cruel world out there. To be able to have those relationships, develop those relationships, and trust and caring. That's what it's about.
For a young person thinking about a career in healthcare, what do you think that they should know about dental medicine? What kind of opportunities are available for them?
I've had the opportunity to talk about this through my experience with Bi-State Primary Care, the Primary Care Association in New Hampshire, which is all about supporting primary care. And when oral health started to become an issue back after the Surgeon General's the Surgeon General's report, the Primary Care Association they didn't know anything about dental. Well, I'm sitting out there. I got a background in private practice, and boy, I've learned a lot in the public sector. So I spent a lot of time with them, and we developed a program and went into the schools, and we would talk. It would talk about what dental practice is like, and one of the biggest things about dentistry is flexibility. And there's a tremendous number. When I was at dental school, there was one woman in my class. Well, now the women are 50% of the classes anyway. And so there's tremendous flexibility. There's flexibility in where you practice. There's flexibility in how you practice, public, private, group, solo. There's flexibility in what you practice. Do you do oral surgery? Do you do periodontics? Do you do orthodontics? There's all this flexibility across the table. That's really great. There's this ability to develop relationships. Like, you talk about cocktail parties, and more often than hearing problems with dentistry, I hear from people how the relationship they have with their dentists. That's out there. The opportunity to the flexibility between the private and the public. Big deal. I mean, a big difference. But that's a huge opportunity. Not everybody wants to run their own thing, but you can develop the same relationships, develop the same teams in a public sector. So going forward, to me, it's a little scary because I think there are some, it doesn't take a genius to realize some variables going on out there right now from an editorial standpoint. Now, I think insurance is beaten up on medicine. Insurance companies are dictating medical care. Well, they haven't done so much in dental, but they're starting. So you get you look at the medical model. There aren't a lot of doctors that practice by themselves anymore. They are owned by the hospital, and the hospitals are owned by the insurance companies. And I apologize for the editorial piece, but I don't think there's any question about it. So that's leaking into dentistry now. It scares me. There's a place for dental insurance to be sure. The statistics, the data is all there. That people who have dental insurance, seek more care than those who don't. But it's a changing environment. What's it going to look like? I'm not too sure. My son owns two small practices. I see a lot of that coming. I think the future of solo practice is iffy in the long run. But what's not going to change is there's two things that have to happen. First, dentistry is expensive to deliver. And so it's still got to be delivered effectively and efficiently. That has to happen. But at the end of the day, the opportunities for professional growth, being part of the medical world, being integrated more and more, because that's what's really happened, right? In the last 10 years with Families First and with the awareness of oral health, much more integrated and the realization of its importance in general health and well-being is there. So that opportunity to be part of that, it's a great opportunity. The opportunity to develop all these relationships that I'm talking about, develop teams and all that. I can't imagine going any other way.
Well, Dr. Homicz, thank you very much for taking the time to speak with us today.
Thank you for listening to me. Appreciate it.
You've been listening to the Health Leader Forge, a joint production of the College of Health and Human Services at the University of New Hampshire and the Northern New England Association of Healthcare Executives. Please go to our website, healthleaderforge.org, for more information or to leave comments about today's podcast. Look for Health Leader Forge podcasts on iTunes, Stitcher, SoundCloud, and other podcast distribution sites. Thanks for being a part of the Health Leader Forge community, and we'll talk with you again in about 2 weeks.